Hi, my name is Erica, and I will be evaluating the thigh thrust test to assess the sacroiliac joint. My objectives, I'll be going over the purpose and positive findings of the test, defining some statistics, then moving on to my research study in statistics, future research, conclusion, and then finally my video demonstration of the test. The purpose of the thigh thrust test, it's a pain provocation test used to determine the presence of SI joint dysfunction, but cannot diagnose SI joint pathology. Often used to distinguish between pelvic girdle pain and low back pain involving the lumbar spine or gluteal area. Women are 8 to 10 times more likely to experience SI joint pain or dysfunction, especially if they are pregnant. For the technique, the patient is supine. The PT stands on the patient's non-painful side and flexes the painful hip to 90 degrees with the knee bent, and then rolls the patient towards them to place one hand beneath the sacrum. The PT then hugs the knee and applies a downward axial pressure along the length of the femur with the other hand to mobilize the innominate on the fixed sacrum. Positive findings include if the patient reports a reproduction of familiar symptoms over the SI joint. Here are the definitions of the statistics I will be using. Inter-rater reliability is the degree of agreement among multiple raters performing the same test. Sensitivity is the proportion of people with the positive test result who had the target disorder, so the true positives. Specificity is the proportion of people with a negative test result who do not have the target disorder, so the true negatives. Positive predictive values are how frequently those who have a positive test will actually have the condition. Negative predictive values are how frequently those with a negative test do not have the condition, and the likelihood ratios represent the probability of individuals with a condition having a positive or negative test divided by the probability of individuals without the condition having a positive or negative test. Now on to my research in statistics. In a study by Laslett et al. In 2005, 48 patients with chronic lumbopelvic pain were examined by physiotherapists using pain provocation SI joint tests and received an injection of local anesthetic into the SI joint. The tests were evaluated individually and in various combinations for diagnostic power. So the sensitivity was determined as 88%, specificity was 69%, positive predictive values was 58%, so this was moderate. Negative predictive values was 92%, which was extremely high. The positive likelihood ratio was 2.8, so this means a positive result is about 3 times more likely in patients with SI joint dysfunction, and the negative likelihood ratio is 0.18, meaning the closer to 0 indicates the test is able to rule out SI joint dysfunction most of the time. In another study by Stuber 2007, it was determined which physical examination tests had the highest sensitivity, specificity, and predictive values for determining the presence of SI joint injuries and/or dysfunction when compared with the gold standard of SI joint block. The study compared the results of several tests from one study to another. I focus only on the sensitivity and specificity of the thigh thrust test, and as you can see, the first group of numbers is from Lassett's study that I just talked about in the previous slide. I wanted to compare the other two studies within the systematic review to Lassett's, and as you can see, in an article by Diffus in 1996, he determined sensitivity was 36% and specificity was 50%, which is relatively low. In an article by Broadhurst in 1998, he determined sensitivity was 69%, which is moderate, and specificity was 100%, which is substantially high. The pain relief standards for injections within each study range from 70 to 90% on the VAS. Also, Broadhurst used the clinical test before and after the patient received the injection and looked at the change in VAS results to determine positive and negative findings, and the other two studies did not. So overall, the thigh thrust had the highest specificity at 100% and relatively high sensitivity according to Laslett. However, a test should have higher values of both in order to be of use in addition to being reliable. Next, I wanted to compare the inter-rater reliability between two different studies. In the first study by Kochmeyer et al. In 2007, two examiners examined 78 subjects in which 59 patients were symptomatic with low back pain and 19 were asymptomatic. They assessed the inter-rater reliability of multi-test scores by using a regimen of 5 commonly used sacroiliac pain provocation tests. The inter-rater reliability is 0.67, which ranges from moderate to substantial based on the 95% confidence interval. This is a reliable method to evaluate SI joint dysfunction. However, further study is needed to assess the validity of this test method. The next study by Lassett and Williams in 1994 assessed the inter-rater reliability of 7 pain provocation tests for pain in sacroiliac joint in 51 low back pain patients. They were assessed by one examiner and another drawn from a pool of 5. The inter-rater reliability is 0.88 with a 94% agreement being highly substantial. As you can see, studies concerning the reliability of individual sacroiliac tests have inconsistent results. It has been suggested that the use of a test regimen is a more reliable form of diagnosis than individually performed tests. One shortcoming that is consistent in most of the studies was the lack of single or double blinding. RCT should be used in future research with control groups. Also, future studies should consider employing a similar test selection process, as it would hopefully minimize the potential bias of authors selecting the tests that they may like or dislike. Also, we need more studies to evaluate validity and reliability of individual tests, because this is an essential quality for a diagnostic test to possess in order for them to be useful clinically. Further assessments of these tests and protocols for reliability are also in need. Such a study should assess as many SI joint tests as reasonably possible. This would hopefully determine the most specific and sensitive SI joint tests or combination of tests to aid with diagnosis. In conclusion, the thigh thrust test is only used as an examination technique to reproduce familiar pain symptoms and provides reason that the patient has some type of SI joint dysfunction if combined with other provocation tests. It is not used to diagnose. There was considerable inconsistency and disagreement between studies within the results and statistics, which makes comparison difficult. However, according to Leslet et al., the thigh thrust has the highest individual sensitivity, therefore performance of this test seems reasonable. Most SI tests have limited supported evidence, however, studies conducted thus far have produced some useful results. No test has proven to be overwhelmingly superior to the others, but combining several tests with higher sensitivity and specificity may allow for more accurate results, although this notion still requires formal evaluation. These are my multiple choice questions. These are my references, and next I will be showing a video demonstration of me performing the thigh thrust test. To begin, the patient is lying supine and a therapist is standing on the patient's non-painful side. The PT flexes the painful hip to 90 degrees with the knee bent. The PT rolls the patient towards them to place one hand underneath the sacrum and then hugs the knee with the other hand in order to provide a downward axial force to shear the innominate on the fixed sacrum. I want to state it is extremely important not to cross the SI joint on either side of the sacrum, so it is important to stand on the opposite side you are testing in order for your hand to be directly on the sacrum without interfering with the joint line. Here is another angle so you can see that my body is directly over the patient's in order to apply the necessary force through the femur. A positive finding is if the patient experience is a reproduction of the familiar symptoms, and the test should also be performed bilaterally to compare sides.